So, John, last week you spent some time at a local conference. I'll call it, and this conference you were speaking, but it was focused on opiate use disorder.
Right.
And you know, I was dismayed by some of the things that you shared that came back from that conference, and I think that this is a good opportunity for us to share a little bit about Hanley and some of the work that we do, what is happening in the behavioral health field,
Right.
really the why behind what's happening, and, you know, talk to our listeners about, you know, maybe not a better way, but a different way to approach opiate use disorder.
And you got it that it's not just the what. If we stop at the what, it's very polarizing and you're going to have people in different camps. But the why actually kind of brings us all together. So the what is that, for opioid use disorder, which is still killing tens of thousands upon tens of thousands of people, opioid overdose,
Yeah.
um, the movement in addiction medicine that was introduced is this idea of medication first. And so the first line of defense is to put people with opioid use disorder on what we call either agonist or partial agonist. That means essentially medicines that will keep people in a state of physiological dependence, right? So they will have to continue to be on these drugs. And the concern obviously is if someone is on these drugs, they're eventually, if they come off of them, they're going to go through withdrawal.
That's right.
And B, being dependent on anything puts you in a state of, boy, if you end up in a hurricane somewhere and you can't get that medicine, then the chances that you're going to go into withdrawal and the chances that you'll go use are really, really high, and it's very dangerous. But the argument for it is, hey, it, people are dying by the tens of thousands on the tens of thousands. And you know what? Every drug and every medicine has side effects, but we can keep people at least alive so they have a chance to get help. They have a chance. And so there are some very real and valid reasons why these medications exist. The one thing though that I heard that's the why,
Mhm.
so if the what is, in fact, what I was saying is that we were told that for certain groups, certain people, like pregnant women,
Mhm.
there are, even if you've not been had an opiate for up to a year, it still is protocol to put you on these medications, which again starts that process not of addiction. Addiction, people have to remember, addiction and dependence are two different things. It's possible to be dependent on a drug. That means you physiologically need it, and if you don't have it, you go through terrible withdrawal. And that's often a part or always a part of addiction, but you can just have dependence. Addiction is this compulsivity to go use, it's accompanied with all of these other problems in your life. But the reality is that, and there was a physician who made this point. He was the same one who was saying, "This is the protocol that we start. I want to start everybody on, an agonist or partial agonist medication, knowing that they're going to be dependent on it." And his point was this. This is the why. If in our country everybody had access to great treatment, everybody could go into care for residential care for 60, 90 days,
Mhm.
and then have
Mhm.
strong community supports and strong therapeutic supports through that first year and year and a half, then maybe this wouldn't need to be the protocol. But the reality is the kind of work that we're able to do at Hanley and very, very few,
Very
literally
few.
very few other places, it just doesn't exist in our country. And so his point is, look, I'm a physician. I don't want anybody dependent on anything if they can help it. But if you give me a choice between alive or dead, I want to keep people alive. And because in our nation, the resources for really good, solid care that's necessary, that they're just not there. And because they're not there, we have to reduce harm as much as we can.
Yeah. Let's break down some of these terms for our listeners. So you use the word uh, agonist.
Mm,
Let's talk about what most people know as Suboxone.
right.
Now, that explain that drug.
So it's actually what's called a partial agonist. And so when you think of the way that drugs affect the brain is every the brain has all sorts of receptors, and brain has opioid receptors, natural opioid receptors, right? So everybody's talking about dopamine nowadays.
Hmm.
Well, dopamine, when we do something that's good for ourselves, right? If you're hungry and you have a nice piece of dark chocolate, you
Hmm.
eat that, and your brain says, "Oh, you did something good for your body, so I'm gonna reinforce this with releasing a little dopamine. Dopamine's like an opioid that attaches to these opioid receptors, and you feel good." So there are external or exogenous opioids like heroin, right?
Hmm.
And you can take that and you can put it into your body and it will bond to those same receptors and it will feel really, really good. And what happens in the brain though is that as that happens, it increases, kind of wakes up more receptors. So now you've been using this heroin, you've waken up more receptors, and now your brain needs even
And
more
more.
to just feel normal. And then in this process called tolerance, you need more and more and more and more. Well, what happens if you stop, let's say you're addicted to heroin or oxycontin or some opioid, and you just take that away, is you've now got all of these receptor sites that start going, "Ah!" They start screaming, right? And they are and you feel sick, you feel, your brain says to you, "You must put something here or you're going to die." And
Hmm.
so people,
Hmm.
despite terrible consequences, go back to the drug, not because they're stupid, not because they're broken, not because they're evil, not because they're weak, but
Yeah.
because this has occurred and they have to go back to the drug. And
And
so
it overrides. It
it it
overrides everything.
absolutely, your world gets smaller and smaller and smaller, and all your brain will let you see is that drug. And so there are a couple of different ways of medically with medicine of dealing with this. There's a kind of drug called an antagonist. And what an
Mhm.
antagonist does is it will bind to those receptor sites and it will quiet them down a bit. But and so that quieting down just a bit
Mhm.
will help take the edge off. But more importantly, if you go back and you use again, an antagonist will essentially not allow that heroin or what those opioids to attach there. And so it gives you some safety and it gives you some time. So when we think of drugs like Vivitrol, right, this is an
Mhm.
injectable drug that's an antagonist and it binds to the receptors. It lasts about 30 days ish per injection and it helps to take the cravings off a little bit. But main thing is if a person goes back to use it, their risk of dying is very, very, very low.
Yes.
Well,
Yes.
there are there's another category of drug, an an agonist, and an agonist doesn't say anything. It bonds, but it has instead of just blocking, think of an
Mhm.
antagonist as something that just puts a cover over the receptor site and won't let other things there. It's not really like that, but it's a good way to think about it. An agonist will bond in the same way that the actual chemical, so an actual opioid will. And so an agonist will decrease the cravings a lot more, and they'll tend to they not only can have that effect of decreasing the cravings, but there are some drugs that are partial agonists that also have a little bit of antagonist in there. And when we're talking about Suboxone, that's what we're talking
Mhm.
about.
Yep.
And it will both give you'll feel the emotionally better, you'll feel physically better, um, but you'll also have this little safety net where you're less likely to overdose.
Mhm.
The problem is that with the antagonist, you get that safety, but patients will tell you that they still are feeling they don't have as much relief from craving. And so it's more work. And they need not only more work, but they need more structure around them for a greater amount of time. Think about a person who truly develops addiction. Man, think about it. They are the equivalent of someone who just got hit by a bus.
Yep. Yep.
If I got hit by a bus tomorrow, I'm going to no one's gonna say to me, and I'm alive, right? Everybody, just to be clear. But I've broken lots and lots of bones, right? No one's gonna say, "Man, I can't believe you need to be in a hospital bed. How weak are you?" Right?
Mhm.
Eh,
That's
well,
right.
of course. And then not only do I need that hospital bed, I'm probably gonna have to go from an ICU. And then when I'm done with the ICU, I'm not done, right? When a person with
Then you
addiction
have to
is
go to PT
yes,
and all the rest of it.
exactly. Nobody's looking at me and saying, or I'm not even looking at myself and saying I'm weak for that. But the reality is with addiction, it's like the brain has been in that kind of terrible,
That's right.
trauma. And so the reality is that that need for treatment that surrounds a person is just like that need for the person who they need the ICU. I think of the detox unit as ICU. It's that acute unit where we start to get on a taper. We don't, very few people. I mean, every once in a while you'll hear these old stories of, somebody just
Yeah.
I locked
I
myself
just
in a room
stopped.
and
Yeah.
and I drank orange juice and shoved chocolate down my throat and I stopped, a 50-year heroin addiction.
No.
It just doesn't
No.
happen. And it's not because of weakness, because the brain is driving you to it. And so it, what we need, first of all, right now, from my perspective, because I was like, man, we're just gonna put everybody with opioid use disorders on medication that's gonna keep them dependent on those medications, and the docs are real clear. Yep. And their point is if we had in our country the supports and the kind of treatment that we need, this would not have to be the first line of defense. And I have to say that I think they're right. And 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 so it puts us all in the same boat. I think the response is not, well, is this drug good or is that I the reality is that there will even be people in our care. There will be people in who have all the supports who will still need a longer time
They do.
on that.
So just so that our listeners know, first of all, we use these drugs very, very commonly when we help people land.
Yes.
Call it landing, call it
Right.
detoxing. We use those and have been using them at Hanley for as long as I've been involved,
Right.
well more than a decade almost. But we do, typically taper people off. Now, sometimes that taper is months long as
Right.
people go through our residential program and then step down. And periodically, we do have people who we recognize, are still challenged with their cravings
Right.
that do stay on, some sort of, MAT,
Right.
medication assisted treatment. But, what we're not doing is we're not bringing somebody in who, has been essentially sober for a
Mhm.
year. And that was the part that I was so dismayed to hear. Somebody who's been sober for a year, you're putting them back on this medication that, in part is an opiate. It has that drug in it.
And that's where I think, there's when I heard this physician, very, very intelligent guy, well educated, addictionologist, and a true authority. And when I heard him talk about this as the first line of defense, it gave me pause. But that idea that it's not about, you know, just loving everybody being dependent on a medication so much, but it's about like what's going to save somebody's life. That what that does is that then it puts us all in the same boat. And thinking about this, the whole concept of, putting on somebody on an agonist when they haven't been on it for a long time. It is something that I think we have to focus on patient preference.
Mhm.
One of the things that and I think
Right.
both sides can, people who are or think that nobody should be on these and people who think that everybody should be on these. I've seen both sides come from a point of almost moralizing it.
Mhm.
And the reality
Which
is
is so wrong.
right. So what we're finding, I was talking to our medical director, and what he told me is, he said, it is my obligation to give patients, every patient,
Mm,
all of the information that I possibly can.
that's
It
right.
is my obligation to give them, honest, their options. And he said, what I'm finding is that there are a lot of patients that will say, because I've heard people say, oh, if you give someone the choice, of course they're going to stay on a drug.
Mhm.
That's not what
That's
we're
no,
finding. It's
no,
not what we're finding. In fact,
no.
he's saying, "Look, you have an, option, at this point to go, you can use, Suboxone or methadone or these." And a lot of patients are saying, "You know what? Detox really sucked,
Yeah.
and I don't wanna do that again. So what are my alternatives?" And so they might look more at, those antagonists. One of the things about these antagonist drugs is that if you stop taking it, nothing happens,
Mhm.
right? Now, you nothing happens that you feel, right? You're not driven. You
Right.
lose that protective factor, and
Mhm.
so
Mhm.
but you don't have this, incredible you don't go into,
Right. And
withdrawals.
that's the drug Vivitrol that you were talking
That's a
about.
great
That's
example.
that's the sort of the leading name with that one.
With opioids especially.
That's right.
Um,
Now talk about what happens if you stop taking buprenorphine, which is Suboxone.
if you stop taking an agonist or a partial agonist, you will go into withdrawal.
Yeah.
And this, the withdrawal. I've had some patients tell me that it was worse than the initial withdrawal from heroin or oxycodone or whatever it was that they went through. Um, and so that's not to scare anybody from it, but
Mhm.
it's important information. We have to get away from politicizing
That's
and
right.
side taking.
And judging. And
Yes, that's
judging
right.
people's choices.
That's
Yeah.
absolutely right. Every every individual is just that, an individual. And I'll tell you, if I had, I've got a 20-something-year-old son, and if I, had a 20-something-year-old son who was also addicted to heroin out on the streets and we had no resources, and without question,
Sure.
on whatever to keep him alive, right?
That's right.
Um, but if I had the resources, the ability, I could get him somewhere, and
Mhm.
and and then I would really say, you know what, it's going to be this is between you and your doctor,
Mhm.
and I think that's the key. I think treating everyone with dignity
Yeah.
and recognizing that each person has the right to choose for themselves how they want to live. Now, that doesn't mean that as an organization, for us, we're not going to try to be all things to all men, but we're certainly going to respect people's rights to make choices for themselves.
You know, let's just talk about um, Hanley's treatment.
Hmm.
And, th- this is what we believe in.
Right.
We believe that residential treatment, quality residential treatment works.
Right.
Um, you know, what we know is that most times people will start with outpatient, and if they fail, then they will go to the next level of treatment. And if they fail that, then they'll go to the next level, and then eventually they'll end up in residential
Right.
treatment. I have to say, and it's likely because I work in this field, but I can't imagine a situation where somebody has a heart attack or, a complete blockage. And we say, you know what, we're going to start you with the lowest
Right.
level of care.
Right.
And if you have another heart attack, then we'll do
Right.
a little more. And if you have yet another heart attack, then we'll do a little more. And eventually we'll do a bypass.
And isn't it even the language,
Hmm.
when insurance companies have done a good job of getting us to use that language of fail,
Hmm.
right?
Hmm.
So we talk about failing treatment. Nobody says you're coming in for your second heart attack. Oh, you failed that first, clearly, right?
You
Nobody
failed
says,
that
"Oh,
first
your
heart
your
attack.
diabetes is out of control again. Oh, you're
You
failing,"
failed.
right? But we do, right? That
Yeah.
and
In behavioral health, that's language that's common.
that it really is driven by payers, by insurance that have got us taught because that's the and we have to use that language again and again and again. The reality.
Just so that our listeners know, Hanley takes insurance. There is a misconception that we don't.
Yep.
We take out of network insurance.
Right.
We obviously we do have some families that private pay,
Right.
and then we also have scholarships. So, we are very, very well versed in what the insurance company is saying, what they're looking for. But the reason we take out of network policies versus in network is our medical team and our clinical team are the ones who really dictate what that treatment episode looks like versus when you are in network, it is dictated by the insurance company, not what the professionals know is best.
And even and one of the things that I'm been at Hanley for a little over 21 years,
You
and
started when you were 9.
that's right. I was 8 and a half. But but it used to be that we couldn't, even take out of network benefits, and if you couldn't, pay for treatment, or get a scholarship, one of those 2 things, then you weren't able to access this level of care. And
Sure.
so there's been so much work, and I'm really proud of that, towards making it more accessible. So, we'll talk about insurance companies and but the reality is, that anything that makes treatment more accessible, and that's one of the things I'm
That's
proud of.
right.
The other is that that sometimes, with out of network folks, the insurance companies will call up and they'll say, "You know what? We're not paying for any more treatment." What happens at a lot of places and a lot of it is you just get kicked out on the street there,
Yeah,
and we don't do that.
we don't.
We do not. We figure it out. If they
We
can't
use
pay
our
for,
scholarship
yep,
dollars. People are there as long as they need to be there. We call that any length.
right,
You know,
right.
whatever is right for the person, not right for the insurance company.
And that's so unique and so, again, it's life affirming.
Mhm.
But, the when we think about the going back to this idea of, that person who's failed treatment, right?
Mhm.
as opposed to in any other chronic health condition, because addiction is a chronic disease. That is the definition. If you want to
Mhm.
look up the definition for from the American Society of Addiction Medicine, American Medical Association,
That's right.
whatever,
Chronic disease.
addiction is a chronic neurobiological disease. And like all other diseases, the big difference between it and other diseases is, imagine, first of all, we blame the person with the disease.
Mm.
And what we forget is that every chronic disease has some behavioral component.
Mhm.
So, if I could use to lose 20 pounds. Could you imagine me going in with a heart attack or with a diabetic condition and then saying, man, you know,
You stopped at Taco Bell again on the way to
yes, I
your
did.
podcast, didn't you?
Got that. No, but yeah, so it's my fault, right? And the truth is, yes, I have to, if I, am not careful, I'll develop, type 2 diabetes, or I could develop any of those things. But at no point is anyone ever going to point the finger at me. They're just going to friggin' treat me.
They're gonna treat you. That's exactly right.
And it doesn't mean that they're, my doc, I have a physician, he's kind of old school and he just tells it like it is. And he will tell me, you know what, you got to drop 20 pounds, right?
Yeah.
It doesn't mean I don't need the information. That's okay. But at no
If you
point,
don't, he's gonna keep treating you.
that's right.
Yeah.
Right. And I think it's so critical for us to look at how we treat chronic disease in our country and where we do it well, and say, "Where are we missing the mark?" Because that's how we need to be treating addiction
Yeah.
also.
I could not agree with you more. Could
I
not
love
agree
that.
with you more. You know, back to where we started. The words that are, unfortunate, I guess, is the physician saying if there was quality
Right,
treatment, the approach would be
right.
different. Um, you know, I know we've talked about this before, but when you guide families about treatment,
Mhm.
what do you tell them to look for in a good quality treatment center?
Well, there's several things. One is a good mix, of historically, treatment centers they'll very often have either a very strong kind of 12 steps spiritually, like really working on you as a human being, or there'll be a lot of psychologists and psychiatrists and they'll be really good at testing, and they'll be really good at giving you worksheets. Um, but the reality is that human beings
Mm.
are physical bodies. We are psychological minds, but there is also a spiritual part of us. And that is, that sometimes people love that. Sometimes people bristle against that. But when I talk about spiritual part, I am talking about that which connects to the transcendent, that part of us that connects to our love for our family, that part of us that connects to awe in a sunset, that part of us that might connect to a sense of God or higher power. But but regardless of where a person falls on this idea of spirituality, every one of us has a need to have a healthy physical body, to have a healthy mind, that psychology, the way we're thinking, the way we're processing, eh, but also a healthy ability to connect spiritually. That means to connect to those transcendent things that give life meaning. And what happens in addiction is all three of those things. The
That's
physical
right.
body is ravaged. The mind is ravaged. People come in thinking their thoughts are, I am bad. I am worthless. I am broken. I did this. I did that. How and their thoughts are, don't trust. Don't, right? And this complete disconnect, and finally, their ability to connect to things like awe or love or a
Mhm.
power greater than themselves, they're numb and disconnected. And so when I think of, people talk about we treat body, mind, and spirit, I hear it all the time.
I love the
The accent
accent.
that I
Yeah,
don't know
that was a
where
good
Ross
one.
Perot just like came from, but
Yeah.
but I think the key is and it's okay. It's important for family members and people who are looking for treatment to know it is absolutely not only you're right, but it's a really smart thing to do to challenge, to ask the questions.
Go tour. Go
It
tour. We love touring families. We
yes,
love touring prospective patients. We one of the things that our listeners will probably think is fun is our packed bag tour. So we have people who are very, very resistant to coming into
hmm
treatment, and so we challenge them. You know what? Come tour, but bring a packed
right,
bag.
right, right,
And I'll tell you, every single time those people are comfortable and they say, okay, you know what, I'm going to admit and, start their journey in recovery. We love those packed bag tours, and
right,
we are happy to welcome families and patients and anybody else who wants to come and see, really what
right.
that combination of body, mind, and spirit looks like.
I love that. And it is, there's nothing like actually seeing it and feeling it and experiencing it yourself. People come on that campus and they say it again and again and again. They have for decades. And I said it. It is that there's something that you feel there. It's hard to explain.
There's magic in those grounds.
Yep.
There's
And
healing, there is life.
couldn't have said it better.
John, thank you.
Thank you.
This was amazing.
It
That
was.
was amazing. All right. Well, I guess that was our guest-less version of the Hanley Effect.
I love it. So now we get to do bloopers the rest of the
The rest
day.
of woohoo,
Okay.
bloopers.
Very nice.
All right. Thanks, everyone. Bye-bye.
Thank you for joining us for the Hanley Effect. To learn more about our programs, visit hanleyfoundation.org or call 844-502-4673.